Welcome to Performance Around the Clock, where we explore the latest research on how to keep our body and mind at our peak physical, emotional, and intellectual performance around the clock. I am your host, Professor Satchin Panda at the Salk Institute, La Jolla, California. On this podcast, we'll talk to leading scientists, clinicians, coaches, and policymakers about human performance. We'll cover different topics, including how different organs and different parts of the brain contribute to human performance. And we'll also learn how our lifestyle, that is, what, when, and how much we eat, sleep, and move around every single day, affect our health and wellness. I hope you'll join me in this journey to explore new knowledge and adapt it in our own life to improve our health and wellness throughout our life. Okay. Welcome to another episode of Performance Around the Clock podcast. Today, I'm truly excited to have Michael Lam as my guest. Michael is a unique physician, scientist. He's an MD PhD, so that means he does both basic research and also clinical research as well as he sees patients. Second, Michael is a board certified internal medicine specialist and also a critical care specialist. So that means he covers the entire spectrum from how to keep people healthy and prevent disease to when people are extremely sick and are in intensive care unit, he also gives them care. Michael is a faculty in the Department of Sleep, Pulmonary Medicine in UC San Diego, and he's also a physician at the Veterans Affairs Hospital in nearby UC San Diego. Michael also maintains a visiting scientist position at the Salk Institute, where he does many of his groundbreaking basic science research. Welcome, Michael.
Thank you. Thank you for having me here. I'm very excited to speak on your platform.
Yeah. Now, Michael and I have been interacting for a very long time because we work together on many different projects, and I'm truly struck by his deep passion into keeping everybody healthy, starting from regular healthy people to keep them healthy, as well as I mentioned, he gives critical care to ICU patients. And in fact, over the last 4 years, he was at the forefront of COVID-19 fight because since he was an ICU physician, from day one, he was in ICU giving critical care to really sick COVID-19 patients. So one key thing about Michael's training is his deep passion into immunology or how a body's immune system works, because if we think about all diseases that affect us, immune system plays a really critical role in keeping us healthy and also fighting off disease, not only for infectious disease, but as we are learning, immune system plays a huge role in keeping us healthy against chronic disease like diabetes, obesity, cardiovascular disease, as well as cancer and dementia. So, Michael, so when we talk about immunity, regular people, we always think about immune system, inflammation. Can you give us some very basic level primer on
Yes.
how our body's immune system works? I know this is a very complicated topic. You
It's
can
a
talk
very
for hours, but then just break it down to
to the basics.
yeah.
I think when I think about immune system, I think about how the system protects the host from foreign pathogens. You can start off with actually the barrier, the skin, the mucosal lining in your nose, your mouth, your gut, your lungs. They play a pretty important role. Then you have proteins that act really quickly when it encounters these pathogens, like complement factors or cytokines that's already existing that can prime the immune system. Then you also have immune cells that also comes into play, and they kind of act in different time frame. The first actor, I would always think about the neutrophils. They will come in first to the site of an infection. It will kill off the bacteria or virus in a very efficient manner. You also have the resident immune cells like macrophages. Those are bigger cells that are primed or specialized to eat up and to kill the bacteria. Um, that's the initial phase of that immune reaction. Our immune system is also very smart. It's trying to train itself to recognize the foreign, the bacteria or virus, such that if you encounter it again, it will be really quick at attacking, protecting the host. And that composed of the adaptive immune system. You have T cells and B cells. And B cells is the one that makes the antibody so that it will recognize the foreign particle. So that's how I kind of think about the immune system. It's a very intricate system that helps protect the host from any foreign pathogens invasions.
So the first line of defense is our skin and all
Yes.
these barriers. So that
Yes.
it's just like the way we think of enemies attacking us. They, having the moats or having big walls to protect the city. So the walls are our skin, and then the lining in our gut, lining in our lungs. So that's the first line. And if bacteria gets in, then you mentioned a few interesting terms, complement factors, which neutralize pathogens.
It recognizes pathogen in a very almost immediately. You can recognize it.
Yeah.
And it can either causes the bacteria to lyse, or it will activate nearby immune cells. Say, hey, something's going on. Better take a look at it. Or get rid
It's
of it.
almost like a taser, right? Taser gun or something like that. So
You could think of it that way.
yeah. And at the same time, it alerts the other immune cells to come to the site. It's almost like the cops calling for backup.
You can think of it that way too. Or
Yeah. So this is interesting when we think of bacterial infection or some infection happens, but we are also learning that the immune system plays a big role in other kind of disease. For example, nowadays the idea is many of the chronic diseases, for example, arthritis, many older people suffer from that, or that really the joint pain, and then cancer, liver disease. So how do immune cells play a role in those kind of disease? Because we cannot connect them to bacteria or virus.
Yeah, that's a really good point. And one of the first reason I was interested in immunology is in medical school, actually. And I saw a study where a gene was deleted specifically in macrophages. And surprisingly, the mouse develop insulin resistance and have symptoms and phenotype of diabetes. When I was in medical school, I was like, you learn about diabetes, you think about insulin, pancreas, liver making glucose, or skeletal muscle removing glucose. But affecting the macrophage alone can cause a diabetic phenotype. I was like, wow, it's so interesting.
So going back to macrophages, macro means big and phage means it gobbles up
stuff. Yes.
So it essentially gobbles up. Typically, the idea is these are these cells that go around, and if they find a bacteria or something, they just gobble them up.
Besides bacteria, it could be many things, including like lipids or even damaged cells it can clean up.
But the surprising fact was if you incapacitate, because you take out a key gene that makes the macrophages tick, and if you take out that gene, then essentially, I think the general expectation is these mice cannot fight infection, but surprisingly, they developed type 2 diabetes, almost equivalent to type 2 diabetes or 3 diabetes, something like
That's right.
Yeah.
And I kind of see it as if you look at every single organ, it has an immune system in there. So I see it as immune cells as communicating with the cells in that environment. If that immune cell is not responding correctly, it affects how the function of other cells. So that's how I kind of learn to appreciate how immune cells are playing a role in a lot of these chronic disease, like the one that you mentioned. If you have like a chronic inflammatory signal, and the immune cell is secreting a lot of factors that's affecting the cells in that organ, you could have chronic diseases, and diabetes is one. After sclerosis, arthritis, those are a chronic inflammatory state that causes kind of pathology.
So there are two terms that come up. One is chronic
Mm-hmm.
and then inflammation.
Mm-hmm.
Is inflammation bad?
So I think the answer is always depends.
Yeah.
And in the right setting, inflammation is great. Like when you have an acute injury, wound, for example, inflammation works great in getting rid of the foreign particle that may be underneath your skin, and it can promote formation of blood vessels, and it can make you heal faster.
Yeah.
But learning how to shut off the inflammations are equally important. And in some case, when that program is altered, then you may have excessive inflammation, sometimes could lead to fibrosis. And when fibrosis happen, or scarring of the tissue, and the scarring can happen, we think of it as on the skin, but it could happen in the different kind of organs, like in the liver or lung, and that can affect the function of those organs.
So in that way, the right amount of immune response is important for maintaining our performance, right? So it's almost like there's a car accident on highway, and then somebody calls 911, the fire truck comes in, and which is extremely important, but then the fire truck remains there for a long period of time after the car is already taken care of, and then the paramedics have taken the unfortunate person. If the fire trucks, 2 or 3 fire trucks, are standing on the highway, then that is chronic inflammation, right?
Yes.
So that's kind of blocking the traffic, and if the fire trucks are still dumping water, then that's also causing more traffic problems. So in this case, what you mentioned, another thing was this immune cells are producing cytokines or different signals that are telling other cells how to behave around the injury site. And so that means there must be a mechanism to reduce inflammation after the damage has been repaired. So how does, another interest of yours is circadian rhythm.
Mm-hmm.
And that's how we kind of came to know each other. So how do you see the connection between circadian rhythm and inflammation?
So first of all, I really like your fireman analogy.
Yeah.
Because they're there to kind of like take care of the issue.
Yeah.
And most of the time they restore the flow of traffic.
Yeah.
It's like homeostasis.
Yeah.
So that that our daily life go back to normal. The freeway is once again flowing.
Yeah.
I think it's just, I think I can extend that analogy to the immune cells and circadian rhythm. I see circadian rhythm as like a homeostasis, a homeostatic state that we're trying to adjust and adapt our body to how the environment is training over 24 hours. And most of the time we will be in homeostasis, but occasionally you would have acute event like an infection, a trauma that is out of the ordinary. Your body has to adapt to those immediate change, to heal, to fight infection. And I feel like that homeostasis is important for the body to kind of return back to a more or less a normal state. And I think I see the circadian rhythm as a homeostasis. I think those two processes may overlap.
I see. So homeostasis is to maintain the body at a healthy state, for example. That's what we usually refer to. But at the same time, we also see that our body is not the same between day and night.
That's right.
Like a body temperature drops, and in fact, it's necessary that we drop our body temperature a little bit so that we can fall asleep at night. Many things go through this up and down. So are there aspects of the immune system that also changes between day and night? So, for example, going back to the fire truck analogy, I always think of during daytime, we're more likely to encounter many types of bacteria, virus, or stress, or whatever it is. And then nighttime, or maybe another time of the day, the immune system already has a pre programmed kind of coming down, going back to means the fire truck going back to the fire station, refilling all the water and checking that they're ready for the next day. So I kind of see it that way. Are there any analogy or are there anything like that in the immune system so that they maybe the immune cells are more
Yeah.
active at a certain time?
The other way to kind of frame the question is, does our immune system work differently at different times of the day? And there are many interesting studies, and some of them are established back in the 1960s.
Wow.
And these are done in animal models. When you can when the researchers are introducing a inflammatory stimulus, a bacterial cell wall component that can induce a massive inflammation. When they do that, and they did the experiment, injected in mice every 4 hours and compare to the outcome depending on the injection time. When mice is injected with that particle at 4 in the afternoon, the survival is less than 20%. But when the injection's at midnight, then the survival is more than 80%.
Wow.
So that's like 4 to 5 times different in survival. And this is with the same dose of that agent. And that study's been reproduced in different contexts. Instead of just the cell wall component, people have tried pneumococcal bacteria for pneumonia, influenza virus, and seems to show a different response based on different times of the day. So, to kind of get back to your question, it's like, yeah, it seems like our body responds to a foreign pathogen differently, respond differently at different times of the day.
Yeah. But at the same time, we cannot control that when I want to get infected or
Oh,
when I should be cutting my
right.
hand to get infection.
Right.
But for regular folks like us, what might be the implication? Like, for example, there are some, when you talk about inflammation, when you talk about immune system, then there are also manifestation of the inflammation in the terms of, for example, asthma or itchiness or other things. Are there indications that these diseases have different severity at different time of the day?
Yeah. So there are many time-dependent variation in disease manifestation that's been documented pretty well. Asthma is one. I think it was noticed back in like the first century
First century.
First century. They wrote it down. It's like, wheezing happened more in late at night. And if you start looking at the epidemiology and looking at asthma, and asthma is a condition where your airway tightens, so it's hard for asthmatic patients to breathe in and out. So they become they have shortness of breath, difficulty breathing. Sometimes if it's worse, bad enough, they have to go to the hospital.
But what is the immune system aspect of the airway constriction?
So it happens, asthma exacerbation actually happen more at night. It can happen more at night. There are ways to assess how patent the airway is, something called peak flow. You basically blow into an instrument, depending on how much you can blow out. And nighttime seems to be worse.
I see.
And when researchers start looking into the immune cells in the lungs itself, there is a flux of difference in cell numbers in lung tissues.
I see.
One of the big player in asthma, it's the eosinophil. Eosinophil is a type of granulocyte in our immune system. It can cause a lot of allergic response when. So researcher actually did biopsy from the lungs at 4 in the afternoon and 4 in a.m.
Wow, biopsy from lungs.
Yes. But I think what they have shown is that you've seen higher number of eosinophils at 4 in the morning. So there is differences in cellular recruitment to the lungs in this case, for example, that may cause that may be one of the reasons why asthma is a little bit worse at nighttime.
So does it mean that people who are taking medications for the asthma symptoms, they should be taking it at a certain time of the day for better efficacy?
Yeah, I think that's a very difficult and challenging question, and it really depends on the person. You know, when they're when do they have these kind of breathlessness episode, and most of the time for asthma, the people are on what we call maintenance inhaler, and those are maybe 2 times a day, so once a day, and most people would do okay. But there were studies done in the mid 90s to early 2000 looking at timing of asthmatic medication and how they would work differently for different individual. And like what you're trying to suggest, if you give a dose at night, sometimes it works just as well compared to giving 2 doses during the day, sometimes better. But what's interesting is they also have an arm where they only give the same dose in the morning, and the morning it's the same as placebo.
Oh,
So there might be right. So the same dose looks like it's more effective at night than compared to the morning.
Oh, so that's actually that has a huge implication because people when they wake up, they actually remember to take most of their medications. They have their breakfast and then most people keep their medications in their medicine cabinet, or they have stuff and then they just means I do that. Sometimes if I have to take supplements or any medicines, if I'm sick, then my reflexive reaction is okay after or before breakfast, depending on whether I should take an empty stomach or after a meal. That's what I do. And a lot of people also do the same thing. So what you're saying is for asthma patients who are taking these inhalers, then it may be if they are brave enough to experiment, because this is not something that everybody's may benefit. There's also another thing that they can try to take the inhaler in the evening and also consult with their physician saying what they're changing, and they can self-experiment.
Yeah, I think being a doctor, I would say, hey, talk to your doctor first before you're trying things. And that's because it really depends on the individual patients, how their profile is, and also depending on the medication they're taking. Sometimes the medication have different half-life. If their half-life is shorter, then this timing of medication makes more sense. And if the half-life is long, sometimes the medication level achieved to a certain steady state. So timing may not be as important. But at least there were some study that was done on these are inhaled corticosteroids or long-acting beta agonists. Those are like mainstay of asthmatic treatment now. That seems to have a better effect for people who have more exacerbation at night by taking it at nighttime or early evening time. That's the best. Seems to be the best.
And what is the mode of action of these 2 types of medication that you said?
Yeah, so the inhaled corticosteroids is thought to play a role in calming down the inflammation. Things like eosinophils are sensitive to steroid treatment, and these are inhaled. So it's only going through the airways. The beta agonist is it helps to dilate, keep the smooth muscle around the airway as open as possible. So that's how we thought that it helps the asthmatic patient.
So the eosinophils, another term you used was these are also responsible for allergic reaction. And then for many, is there any study showing that allergic reactions are more severe in the evening? Because if this is so, then the allergic reactions more severe. And then the obvious question, if you're taking antihistamine or the other medications to fight allergy,
Yeah.
are they more effective or the side effects more manageable if taken at certain time?
Now I can only speak to more like allergy as what we think like hay fever, that type of allergy.
Okay.
And there's another group like anaphylaxis, like
Yeah, that's
allergy. That's a very different thing.
So maybe we can discuss a little bit anaphylaxis and hay fever type.
So for hay fever, I know sometimes I experience it myself. It's worse at night. That this is when you have like itchy eye,
Yeah.
scratchy throat. You will start having runny nose. Sometimes it's worse at night, and at least for me, if I do antihistamine around the evening and doing additional treatment like nasal rinse,
Yeah.
and also use nasal corticosteroids, it seems to help better. But that's just me. And I do think that there are things that people can try, and if it works for them, great, and let their doctor know. And doctor, if they agree with it, I think that's as long as we're not doing harm. I think that's the first principle in medicine.
Yeah. So the hay fever, it comes from the word hay because people who worked in a farm, they got this kind of fever or something like that? Or
That I don't know. That's how I would imagine.
because what I experience is, once in a while I do actually go work in my garden. Particularly, most of the work happens when the garden is too many weeds that I'm cleaning up. And then I have noticed that I do kind of feel itchy and have a little bit of fever. Is then my standard of practice is if I work in the garden, I'm wearing mask these days so that I don't inhale a lot of potential allergen that are present in a weed full of garden. That's mine. And then second is, it's almost like I'm in a sea of allergen. So when I come back, I just remove all those clothes for washing and then take a good shower. And as you said, I do also nasal rinse to make sure that all as much allergen as I can remove from my body. So that's. But you are also mentioning, of course, I haven't taken much antihistamine lately because I haven't seen one
Great.
years.
Great.
But if it is so, maybe I'll call you and then ask.
Sure. Yes.
So that's kind of the milder version of allergy that most people experience. But then you had another term, more severe form. Can you explain?
Yeah, that's a different types of allergic response, and that's when that will actually lead to a release of a cytokine we call or what we call histamines.
Yeah.
And then it will cause a lot of severe reaction, mostly swelling, and it can also lead to the when it swells, your airway may be swollen. It could be occluded. People may have difficulty swelling. Their oropharynx, their mouth can also be swollen, so it may be difficult to talk. And sometimes also affects the circulatory system. Blood pressure may drop. So those are pretty severe form of life-threatening allergic reaction, anaphylactic reaction. And we need to we treat this patient with like high dose steroids and give them people may be familiar with EpiPen.
Yeah.
And if they're severe enough in the ICU, we give them epinephrine through the to the blood using IV, just to calm down that allergic reaction.
Yeah. Is there any historical data that this kind of anaphylaxis also happens more frequently at certain time of the day or night?
That I don't know.
Okay.
That I don't know.
That's the thing that I like about Michael, because we work at Salk Institute, and one of our presidents was Francis Crick, and he was humble like you are, Michael, because whenever he did not know something, he would say, "I'm sorry, I should have known this. I don't know. I'll look it up."
Yeah, no,
Michael, thank you for being so humble, because a lot of people don't just keep on talking. Okay, so then the question is, well, if at certain time of the day or night the immune system is behaving differently, what might be the underlying causes? Because we know that there are many hormones that go up and down at different time of the day.
Mm-hmm.
And there are a lot of research showing how hormones talk to the immune system.
Yeah, for sure.
Best example is the stress hormone, corticosterone. So can you tell us a little bit about how corticosterone goes up and down and how they affect the immune system?
So I think of corticosterone in two camps. One is physiological, one is pharmacological, because we, as a pulmonologist, intensivist, and it goes well with many other specialty too. Steroids is actually a very helpful medication in select cases, but we usually give the steroid dose much higher than what our body produces. But back to that physiological level, there is a rhythmic pattern of a steroid level in our system throughout the day. When we're sleeping, it actually goes down to the lowest point, and the highest point in a normal individual is when they're about to wake up, and that's when you see the corticosterone level goes the highest, and then it will slowly go down with respect to the rest of the waking hours, and then later again when you're sleeping. So that seems to be the daily rhythm for corticosterone.
So that's why waking up is so stressful.
For me, yes. Would like to stay in bed for a little longer, but no. Kids have to go to school.
Yeah, so then how corticosterone that affects the immune system? Which type of cells? What kind of effect it has?
So steroid, glucocorticoid. So corticosteroid, it's received and sensed by immune cells through a transcription factor, glucocorticoid receptor. GR. And it receives the signals. The GR will move from the cytosol into the nucleus and changes gene expression.
So the nucleus is where the DNA, the blueprint of our life, is stored.
That's right.
And then the cytosol is where the blueprint is being translated or decoded into our cell function.
Yes, and so GR changes how the RNA, the mRNA, the protein is being made as an instruction from the signal. So in a way, the cells will receive the signal, say, hey, there is glucocorticoid around. This is what we should produce from the DNA, the instruction. And that GR actually exists in most immune cells, a lot of immune cells. So this includes macrophages, T cells, B cells, neutrophils, eosinophils. So they exist. So I think all cells would sense glucocorticoid. Now their steroid function is complex because it, I think, has to do with the dosing. If it's the dose that we used in the hospital or for a certain disease, I believe those doses would have that immunosuppressive effect.
Mhm.
Sometimes when we give patients steroids up to a certain amount, like prednisone, more than 20 milligram a day, for example, we will ask them to say, hey, we need to start thinking about side effects of prednisone. One of it is immunosuppression. So we give a antibiotic to them so as a prophylaxis so they do not get opportunistic infection.
Mhm.
So I think at higher dose, it has an immunosuppressive effect. At the physiological dose, there are some studies that show, steroids are actually good in promoting immune cells to do what they have to do.
Mhm.
Things like macrophages will be eating up other things, phagocytosis. So I think steroids has different effect on different immune cells.
But our body's own steroid that we produce is always in the optimum range, so that at least this day-night cycle in steroids can activate immune cells at a certain time and then take away that activation signal so that the immune cells can go back and, in layman term, repair, reset, and
Yeah,
get ready for another day.
that's right. And corticosteroid also affects many other organ function too. So there are diseases where when the corticosteroid is made from the adrenal gland, after receiving signal from from the brain, there are conditions when the adrenal gland is suppressed and they're no longer producing enough corticosteroid. Um, Patients like that may feel really tired, or have low blood pressure. So it's important for the function of other organs as well.
So conversely, when people are stressed,
Yeah,
chronically stressed,
yeah,
or they're doing, even people who are going to the gym doing a lot of resistance trainings at night time when your cortisol levels should be actually declining. Um, I'm not sure how much corticosterone increase happens if you're in the gym and doing excessive weight training, or maybe um, kickboxing or doing something like that. So that can also lead to. It's not that you should not be doing exercise. One thing. No, exercise is the best medicine, one of the best medicines you can have for many things. But we are talking about factors that might increase your stress hormone, whether excessive stress in the evening, mental stress, worrying about too much, or physical stress. So, do you think that high level of continuously high level of corticosteroid can lead to chronic inflammation? Is there any
yeah. So
scientific studies?
that's the thought. I mean, there are activity that increases corticosteroid, like you mentioned, exercise. But after exercise, you have a cool down period, right? So that the steroid level, I think, I don't know, can't recall a study, but it should also come down too. Uh, um, so I think that's very different from having a chronically constant elevated state of steroids. And there are some pretty good study actually looking at sustained release of exogenous steroids on mice that can change metabolism. So I do think you're right that a constant elevation of corticosteroid have adverse effect on the body function. This could be immune or metabolism.
So this is how we're kind of discussing how cyclic levels of corticosterone in the body, which peaks at wake up time and reaches its trough level or minimum level in the middle of our sleep, affects the immune system so that the immune system might have a rhythm.
Mm-hmm.
But you also did some pioneering studies showing another connection between circadian clock and the immune system. Can you tell us a little bit?
Yeah.
Yeah.
So I think the more we look into circadian clock, the more complex it gets. And it feels like I think the thing is there are redundancy in the circadian clock such that it's not dependent on one signal. And I think what we have done, or what I've done, is if you take the immune cell out and in an in vitro setting where it no longer receives signals from the body, you could still see a rhythmic pattern in gene expression and also activation to LPS. It's not just me; other people have shown it too, and that part is very interesting and exciting. Um,
So what are these experiments? You take out the immune cells out of the body,
mhm.
put them in little plates with some media.
Yeah. So you can grow those immune cells on a plate, put it in a incubator, 37, so they will be happy, and you can synchronize them so that all of them will be at the same time,
Yeah.
same frame, and then you could start looking at their rhythmic expression pattern. For example, like gene expression, every 4 hours you would see a rhythmic pattern, like a wave pattern for certain genes, particularly the circadian clock genes. They you see that in cells. We have done reporter assay too, where there is a gene that gives a glow, basically makes the cell glow, and that gene is under regulation of circadian pathway, and you can see that macrophage immune cell can have rhythmic pattern once you take them out from the cell. What that means is that the cell itself can have the clock on its own. So
then you mentioned another thing, LPS treatment. What is this? So if you challenge these immune cells with some pathogen, then they react differently.
Yes. So LPS, it's like a cell wall component of a gram-negative bacteria, and our cells have a receptor that recognizes it, and once the cell recognizes it, it has a very robust response to basically a foreign signal. The macrophages or immune cell will be activated. One form is you see a massive change in gene expression. You would start seeing cytokine production, killing, for example, bacterial killing. So under that experiment where we get the cell out, put them in a plate in a 37-degree incubator, and if you add the LPS at different time of the day, they do respond very differently in terms of the gene expression. They can have 2 to 10-fold difference depending on when you activate the macrophages.
So do these translate to the macrophages being more potent in? Of course, here you are not putting real bacteria. You're just mimicking the presence of bacteria. But can the macrophages be more active in phagocytosing or eating up the bacteria? Or that might be explaining all the experiments that you mentioned, that at different time of the day, when you infect the mice with different bacteria, either they die or they survive.
So there's a really nice story done by a different group. They look at, I mentioned about toll-like receptor 4 recognizing the LPS. There's another toll-like receptor 9 that recognize bacterial and viral DNA. And toll-like receptor 9 has a rhythmic pattern so that it is expressed higher at a certain time of the day. When the group that have done an experiment to cause sepsis at the time when TLR9 is the highest, it seems to have worse outcome. So that may be one of many mechanisms explaining how immune function may change at different time of days, when that the machinery that recognizes the foreign signal may be more active at a certain time. Therefore, the body may respond differently at different time of the day.
Yeah. So so far we have been talking. We covered 2 topics. One is the allergic reaction. So how that might be very different at different time of the day, and potentially after talking to your doctor, people can figure out whether they should take the inhaler at evening or morning and try to see how it changes. Then on this infection part, we actually don't have much control over what time we can get an infection or not. The third thing that he mentioned was adaptive immune response, or how our body reacts to initial encounter with bacteria or pathogens and then produces antibodies.
Yeah.
And is there a circadian rhythm to that process, or is there any evidence that this memory of fighting the bacteria is much better if we encounter, in this case, may not be with the pathogen, but with a vaccine, because vaccines essentially are mimics of pathogens.
Yeah, like vaccine is like training our immune system to recognize a foreign agent that could be harmful. So it's like training our army before it recognizes before the invasion, basically. Yeah. And interestingly, people have looked at vaccination at different times of the day, and maybe not surprisingly, it has an effect. And multiple groups have done this on different different vaccine, like hepatitis A, hepatitis B, and even COVID seems to have a time-specific effect. There's this one really nice study that was published earlier this year, looking at the medical health record from Israel. Israel is interesting because every one of the citizens have free healthcare, and they have a nationalized medical record system, so you can know exactly. So when they get their vaccine, they know exactly when they get the vaccine. At the same time, you can
when means what time of
the day they get the vaccine, and during the initial wave of the COVID, they were able to administer the same vaccine to the entire nation. So I believe it was like a very high number of medical record that they can look into. What's also good is that if the people are sick, they went to their doctors for confirmed COVID cases. You could also see, and you could link that back to whether or not, if you get vaccine at a certain time of day, you have more breakthrough cases. And I think that's what they have saw. They discover is that when the vaccine was received or given in late afternoon, they tend to have more breakthrough cases for those individuals.
So in other words, the vaccine was slightly less effective. It's not day and night. Like, it's not that everybody who got vaccine in the afternoon had no effect of the vaccine, right? To make it clear that any vaccine was better than no vaccine. But those who got the vaccine in the afternoon had more likely to get a symptomatic COVID-19, because only when they got the symptom they went to get tested.
Yeah, then that's when they see the doctors in ER, and that's how they can see that record.
Yeah.
Yes.
And those who got the vaccine in the morning are less likely to develop symptomatic COVID-19.
That's right. You said it perfectly. Okay. Yeah. And when they start breaking down subgroup, it seems like those who are 65 or above had that difference between morning versus late afternoon vaccination. So it's interesting because it actually shows that first of all, there is a time-specific effect, but at the same time, it's not the entire population. It's only a certain group of patients, a certain group of individual. So in that case, you can start thinking about maybe for a certain group of the population, it's better to get vaccine at a certain time of the day.
So that means the young people can go and get vaccine any time of the day, so that there is less line in the morning, and then we can have the older, the wiser and older adults to come early in the morning to get vaccinated.
To be specific, though, I think that study showed that the youngest group and the oldest group had effect.
So both groups had effect.
Whereas the group in the middle doesn't see the time of day. The difference is not observable. Okay. but
So the grandparents can take the
their kids
for
early.
vaccination in the morning, and then the rest of the population can go whenever they want.
Yeah. And in a way, it makes sense, right? You cannot force, or it's hard to implement vaccination only certain time of the day because you may not have enough manpower to do that or
Yeah.
time slots. So it's good to know that only certain group of individuals may benefit from this kind of like time-specific treatment.
Is it also effective against flu? Because a lot of people get vaccinated against influenza almost every year.
Mhm.
I do get vaccinated every year.
I'm trying to recall whether the study. I need to do some
Yeah.
digging, but at least for example, like hepatitis,
Mhm.
maybe influenza too. Morning seems to be better.
Yeah.
And it's also interestingly for influenza, if I remember correctly, it's also done in those who are above 65, as they saw a seems like better effect in the morning. And I have to dig back whether because the paper's outcome is important, whether to measure the actual infection versus just antibody level.
Yeah.
I think the influenza they measure the antibody level and not the actual infection. I may be wrong, but they saw an effect on morning vaccination tends to be better.
Because maybe Jeff Haspel, who is the first corresponding author, we should ask him. He should go back to Israel and get all the records of influenza time of the day vaccination, and instead of antibody level, actually serious cases of influenza. Because I'm not sure whether influenza is more serious among older individuals than among younger. Because if it is more serious among older adults, then it makes sense that they can reduce disease severity by getting the vaccine in the morning, if it is true. And that has a bigger impact on healthcare burden and healthcare expenses.
I think so. Yeah. And I think there's a lot unknown. And study like Jeff's, I think it's insightful that we should be cognizant of like maybe time of day makes a difference. And sometimes because vaccine is given to so many individuals, a small effect size may translate into large number of patients benefiting from intervention like this.
Because I think if we now fast forward and say, this is where your expertise in ICU also comes into play, because an average person, when he or she got, say, COVID-19 and got hospitalized, or an average person who gets flu and gets hospitalized, on an average, how many days do they spend in hospital? It's not just one night.
No. I mean, they can. It varies. Yeah. And for COVID, on at least the patient that I took care of, they can spend a median of up to 17 days. 17. 17, yeah. 17. So 2.5 weeks. Yeah. Yes. And and these are the sickest patients. Yeah. Where they're mechanically ventilated, they're life support. And since we know they have COVID, and sometimes we give them time to allow them to recover. Yeah. That's why, that they have extended period of stay. So that means even if these vaccines have an impact of reducing hospitalization, say 1,000 people. So that's 17,000 days of ICU stay. Yeah. And when you're looking at, say, 100 million people in the US who may be above the age of 50, then you may be looking at really billions of dollars in savings from hospital stay. Yeah. So I think that this is impactful, because if you can just change the timing of vaccination, and that will lead to billions of dollars in savings in healthcare costs. That's huge. That's huge, and it can also, let's say, if it works better, you do save life. Yeah. So it's a combination. Yeah. And also, Vince, we are not talking about the
societal burden, because
Mhm.
there is a societal burden, there is an emotional burden of somebody falling sick,
Yeah.
and that is priceless. We cannot put
You
a
cannot put
dollar
a price
figure.
on
We
that.
cannot put a dollar figure,
Yeah.
but for policymakers and for public health initiatives, where we are always thinking about the return on investment in terms of
Yeah.
real dollars.
Yeah.
It does help to highlight this point so that this can be there can be more studies first, because this was one study in Israel. So let's figure out whether there are more studies like that.
Yeah.
And that will slowly move the needle.
Yeah, I think so. Yeah.
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 So now the converse case is we talked about how circadian rhythm, having a good circadian rhythm is good for us. And having disrupted circadian rhythms.
Mhm.
And you have experienced quite a lot of it, because you yourself, I think when you're in ICU, you are staying up all night or 24 hours, and you have disrupted circadian rhythms. But does disrupted circadian rhythm increase our chance of infection? Are there animal studies or human studies? For example, you mentioned that if you take mice or rats and infect at different times of the day, you see different outcome.
Yes.
But if you take the mice or rats and then
Yeah.
disrupt circadian rhythms, what
Yeah.
happens?
There are different ways of disrupting circadian rhythm. One of them is by the environmental cues, and you could keep the animal model in like constant light or constant darkness, and that will disrupt the circadian. That's one way of disrupting circadian. And interestingly, that circadian response to LPS,
Mhm.
that was done again with circadian disruption, and that rhythm mainly goes away, but the mortality now is just high
Wow.
on all the time points. So that may be one indication that um, uh, if you have circadian disruption from that standpoint, it can worsen an inflammatory response.
So that means if you're a regular mouse getting regular sleep and 3 meals a day or whatever equivalent for a mouse, then getting that bacterial infection when the mouse was resting, for example,
Mhm.
might make the mouse dead. There is a 50% chance, but
Yes.
then at another time the chance was pretty low. But if the mouse is jet lagged,
Yeah.
or the mouse is doing shift work,
Yeah.
then that mouse is more susceptible to death. We are not talking about being sick, just extreme case,
Yeah.
like death from
Mhm.
bacterial infection. So that poses an interesting question that relates to all of us. Like, for example, many people say when they travel, they jet lag and then they catch some bug from the airport or airplane. And is it that they are catching the bug, or the immune
More
system just
susceptible.
kind of more susceptible? So that's why they're falling sick.
Yeah, I don't know, and but there are some study. For example, we think about sleep. Sleep is different from circadian rhythm, but if you force a certain individual to stay awake, and then give them a rhinovirus, a common cold virus, those who have sleep disruption, they tend to have symptoms
I see.
compared to people who have good amount of sleep, given the same dose of the virus. So there are evidence saying that yeah, your immune system is probably weaker in that case, or a viral infection.
So you mentioned that sleep and circadian rhythms are different.
Yeah.
And this is interesting because, in academics, we know that sleep and circadian rhythms may be different, but for everybody else, when I go and talk to people saying, hey, I work on circadian rhythm, the first thing they tell me is their sleep problems. um, so the point is, sleep is just one aspect of circadian rhythm, right? So one can habitually sleep during daytime, but may still have a okay circadian rhythm. That's what you're meaning to say, like the night shift workers when they are working at night and then sleeping during daytime. If they get enough sleep, then that's okay.
I don't know if that's okay, because
I
again,
mean, it's not the best.
it's not.
Yeah.
And and it's interesting because we live in a society when everything happens 24 hours a day,
Yeah.
and a significant proportion of the population are working
Yeah.
shift work. So understanding that is very important. And some studies are suggesting no, it's not good for shift worker.
Yeah.
And I think it's dependent on certain individual. Some people may handle it better. Some people are, or they're made different. People are different. They're unique. So some will handle better that constant shift between nighttime, daytime, nighttime. Some people will not do well. For me, I know when I'm on night shift, yeah, I have bad behavior. I go look around for food and I eat a lot more. So I probably not a good handler for shift work. But I think back to your original question that whether sleep and circadian, people think that they are related, but they're not equal to each other, meaning that you could have sleep at different time that could be separate from the circadian phase.
But I guess the take-home message is one should sleep enough
Yeah,
every day, because that itself is very important. And when the regular folks who are fortunate enough to sleep every night, say go to bed between 10 and 11 or 10 to midnight, and getting 7 to 8 hours of bedtime, that's okay. But we're talking about when people are traveling,
yeah,
since that circadian rhythm disruption or sleep disruption, whatever it is, because both of them happen hand in hand. Because if you have a morning flight, you're waking up early, you have disrupted sleep. And if you're flying back and by the time you reach home, like sometimes I reach home at midnight or 1 o'clock, and then next day morning I have to come to lab. So you reduce sleep. So the bottom line is when you have circadian rhythm disruption, your guards are down, so you're more likely to if you get infected, then you're more likely to show severe symptoms.
or maybe show symptoms.
So that means when we experience the circadian rhythm disruption, travel or anything, then we have to be more vigilant against potential infection.
I think
Is that the point to means for regular people, is that the take-home message?
I think I think so. I think if you're being more conscientious about potential infection, like don't rub your eyes or wash your hands before you eat. I think those are good.
Face mask.
Face masks. Those are good unharmful practice that may prevent you from having being symptomatic.
Yeah.
And sometimes these symptoms could be mild, like maybe a day, like maybe 3 days of having cold symptoms. But you still want to be productive.
Yeah.
You want to go back to the lab the next day of travel. So if that helps, yes, I think that will be helpful.
Yeah.
Be conscientious about.
But then, so you brought up another point. It's not that nobody will fall sick. Everybody falls sick at certain point in their lifetime. Then the question is, when you are sick, whether it's we went through hay fever, cold symptoms, some people might get a throat infection, UTI, stomach bug. An average person gets all of this.
Yes.
So then how does your research into sleep or circadian rhythm come into play? What do you recommend your patients?
It's always listen to your mother, right?
Okay, I will not listen to you.
And I think the old saying has, they have wisdom, and I think eat right, sleep right. I think that makes a lot of sense. When we're sick and and this is more like systemic, you could feel it. You naturally feel tired.
Yeah.
And that's I think a signal for you want the body. It's kind of out of its homeostasis. Sleep kicks in. Yeah, and I think there's thought to be a protective aspect of sleep in that kind of situation. You may be sleep longer, the sleep may be disrupted, but it's okay. That's how the body kind of tells you what to do. And I think those under those situations, yeah, listen to what your body's trying to tell you. Uh, um, but at the same time, and also during those times, you don't want to eat.
Yeah.
Yeah. And I think your body has to go through this abrupt change and it has to return to homeostasis. And I think at that point, then you try to sleep at a regular schedule, eat at a regular schedule, drink plenty of fluid. I think those are the best way. And of course, depending on what kind of sickness, you should talk to your doctors, because sometimes if it's a bacterial infection and you treat, if it's a viral infection, sometimes the body can resolve on its own. If it's any other chronic illnesses, the treatment is very different.
So then, we're talking about infection, and then in extreme cases, people do go to hospital.
Yeah.
And then they get into ICU.
Mm-hmm.
And in ICUs, we know that in every few hours, patients are poked. For good reason, because the physicians are trying to figure out what's wrong. And the life is on critical stage, because any miscare or delay in care can cause more severe form or even death. So how does circadian rhythm disrupts play in ICU? Because ICU is in a very constant condition.
Yeah, it's a constant.
And what is the average time people get for their sleep? What is the average length of sleep in the ICU?
Yeah. So in the ICU, when you say it's constant, we think about light, noise, interaction with others. In this case, mostly the nursing staff, the respiratory therapists, physical therapists, doctors, blood draw, and it occurs throughout different times of the day. And for reasons because we need to know the answer soon, and so we could give the right treatment or provide treatment that require very frequent, so that the nurse have to go in, give the medication. Sometimes it interrupt sleep or circadian pattern that way. The question is, how do you measure circadian rhythm in a sick patient that are in the ICU? And a group in Chicago, they look into the gene expression in the peripheral blood, and they saw that the rhythm is basically gone for a lot of clock genes, and they get better as the rhythm recovers, as the patient recovers. There are other ways of measuring circadian rhythm, but it's hard because I think because the patient, or as a human, your condition is very different during that particular state. So I think the internal clock may be disrupted at the time, and the environmental disruption is also present because of the urgency of medical needs.
And I often hear that many ICU patients get into delirium. Can you explain what is delirium, and what happens, and how severe it is, or how does it interfere with the type of treatment they receive or the efficacy of the treatment?
Yeah, so in the delirium, it refers to altered mental status. Cognitive function is not at adequate capacity, and sometimes poor attention, poor response to command, and they may have misbehavior, difficulty following direction, and sometimes non-responsive. Those are patients that are mostly unconscious or acting not like their normal self. And delirium also has a definition that it waxes and wanes. Sometimes they act normal, sometimes they act normal. And this has to do with the mental states. And patients that have delirium, either in the ICU or in the hospital, they mostly in the ICU, they would have poor outcome. if we start detecting delirium. And delirium can cause by multiple issues, the disease illness itself, or the medical treatment that can also lead to delirium.
So what percentage of ICU patients roughly?
Yeah, it's a large portion. I don't have the exact number. I should have prepared for it, but I don't
It's
know.
not
But
1 or 2%.
no, it's I think it can be close to 50%.
Wow.
Yeah,
So
it's
nearly
quite
one
frequent.
third to one half
Yeah,
of patients
it's-
can develop delirium where they have. I guess what I hear from some people is they lose the sense of time, the sense of place, the sense
of
of
self.
context,
Yeah,
and sense of self.
yeah. Mhm.
And then you have to administer more drugs to take care of the delirium state. Or
Yeah, there are
does that
multiple studies that try to address for delirium,
Yeah.
and unfortunately, most of those studies have negative results. And I suspect it's because delirium, like in many things in medicine, it's a syndrome. I
see.
think within that group of patients, there's many reasons why the person becomes delirious. So sometimes one drug may not treat everyone the right way. But when patients are in delirium, sometimes we do treat with medications, and because we don't have data to say that medication works, sometimes we just try our best.
Yeah.
But that ends up with giving patients more medications, and sometimes we have to balance the risk and benefit, and sometimes there are risks, and that can cause more harm by giving medications that way. So.
And is there any circadian aspect? Like, can we impose light, bright light,
Yeah.
dim light, or
So I think something that makes common sense is that because, like you said, ICU is a very routine environment. Yes, there's if you go to ICU in the daytime, there's light, and at night, the nurses and the staff are really trying their best to kind of dim the light, lower the noise. But it's not the same as the light that we are exposed to. Usually, daytime, the light may be up to 500 lux.
Yeah.
Whereas if we go outside, it could be 10,000 lux. So patients not experiencing that. So it makes sense that if we are trying to optimize those environmental cues, so that patient know what time of day they are in, either by light, reducing environmental noise, minimize interaction that's unnecessary. It may minimize the delirium. And one movement, at least in many of the ICU, is trying to get the patient as active as possible, something called early mobilization, so that the patient could actively be involved in their care. And it's hard because a lot of those patients are still intubated on a breathing machine. So there's a lot that goes into it to make that possible. But I think there's a cultural shift trying to push towards that. So in combination of light, noise, early activity, and maybe feeding, trying to optimize those conditions for the patient to recover.
So I guess the bottom line is, if I get into an ICU, unfortunately, then I should insist that I should have a large window in my ICU unit so that I can get some sense of when it is daylight outside.
I think that's a good architectural design that can promote that.
Yeah.
Older hospital, you would see, and this is anecdotal from my own experience, patient in rooms that have no windows, they tend to have
What's
delirium.
delirium?
And that, one thing we know for sure, it will prolong hospital stay.
Yeah.
And so those are some of the adverse outcomes from that. And usually when we round the morning, we say, let's try to find that patient a different room where there's a window and make sure that if the nurse or a sitter or if they're lucky, the family's bedside, trying to interact with them, the patient, during their daytime, during the normal phase. So hopefully they'll get back in sync.
Yeah, so I was lucky enough that you gave me a tour of your ICU facility in the new Jacobs
Medical center. Yeah.
Medical Center, and I was really, it's truly impressive. Like these ICU rooms are so well designed. It's almost a floor to ceiling wall, sorry, the glass
Windows,
walls,
yeah.
right? Glass windows, and then you got plenty of light during daytime. And then at nighttime, I guess you took me during nighttime. It was really dimly lit.
Yeah.
And I was really impressed, like to see how the concepts of circadian rhythm has really percolated down to designing principles for ICU or hospital where the patients are going to spend several days, a very critical period of their lives. And it'll be interesting to see. Of course, this is very difficult. These kind of studies are very difficult
Yeah.
because once you show that having large windows are good for the patients, then the problem is the liability from patients who are unfortunate to be in the ICU unit where there is no window.
windows.
So I have been in those situations where I wanted to study this kind of stuff, and then the lawyers came and said, no, you cannot study because if there is benefit, then we are liable that we are not giving optimum care to the rest. So hopefully soon this will be a standard care that most ICUs will have at least a window or a digital window, because what I'm also seeing is now the cost of digital wall has gone down so much that you can actually have a
Yeah.
almost a digital wall that mimics the outside outdoor. So sometimes you can even have the live web feed from say La Jolla shore or from a beach from Hawaii projected to the wall of an ICU patient. And it'll be interesting to see whether that has impact. Another thing that you mentioned is many ICU patients also get food intravenously because they cannot eat.
Yeah.
And most of this nutrition is also 24/7.
Yeah.
Is there any study showing, means we know that maintaining a eating fasting schedule is much better for healthy people to stay healthy or people who have chronic disease to improve their health. But has there been any study that in ICU patients or hospitalized patients or critically ill patients it has any benefit?
I can think of one study that looked at the pediatric population.
Yeah.
These are younger patients who receive bone marrow stem cell transplant. And they usually have to stay in the hospital for a long time because you have to wait for their bone marrow to kind of engraft and to come back. And sometimes they do receive nutrition through the IV. And there was one study that was done to show whether doing a continuous, we call it TPN, total parental nutrition, 24 hours a day versus limited time, I think for a 10 to 12 hour window. Now that study didn't, it was more like a feasibility study and safety study, and there was no adverse effect. They did show that the patients can take oral intake earlier compared to those who just have a 24-hour TPN. So in a way, I think that's significant because being able to eat by mouth, as a doctor, it's like, this is a good sign.
Yeah.
The patient have appetite, they can tolerate
Yeah.
eating, and they're not like having vomiting or diarrhea. So that's a good sign.
Yeah.
And whether or not it has an impact on a clinical outcome, I think we're waiting to see more study.
Yeah. No, so this is important that many of us, we think that when you are sick, when a person is sick, this person needs more food or frequent food throughout day and night to fight the disease.
Yeah.
But what you mentioned is these patients who are going through bone marrow transplant and pretty severe stuff, and then these patients have to actually, the body has to fight a lot of stuff, the trauma of the surgery and also the new transplant and being on, I guess they're also in immunosuppressive medication or something.
They would get a dose of medication that suppresses,
The immune
basically get rid of the bone marrow,
Bone
their
marrow,
bone marrow. Yeah.
And in these kids, just feeding them for 10 to 12 hours or having few hours of no food had no adverse effect.
Yeah.
It did not do any harm. That's one thing. And second thing that you mentioned is when they can eat themselves, that means their appetite. So the brain is telling the body to feel hungry at the right time or at some time, and then they're digesting that food without diarrhea. So that means their gut has recovered, so it can digest food, absorb the nutrient, and hopefully the gut microbe can tolerate eating solid food. So that's huge. So
That's
that means
huge. That's mhm.
so this means it has multiple effect. Gut brain axis, digestion, then the liver has to absorb and use that. So this is really interesting to see. I think this is just the beginning, because if it is a feasibility study, then it will be interesting to see
Yeah.
whether larger studies will hold ground. This will have a bigger impact.
Yeah, I think so. And prolonged TPN
Mhm.
is also an infection risk, because imagine you're giving very highly nutritional
Yeah.
supplement through the blood, through the IV. Sometimes we think about that as
I see.
a risk factor for nosocomial infection,
Mhm.
fungal infection. So the earlier we could liberate the patient from TPN and they can tolerate oral, the better, in my opinion.
Wow, that's really cool. So then the last part is, well, we have gone through many stages, what healthy people can do when they fall sick but are staying at home, what they can do. And then in the extreme cases of ICU, when people get out of ICU, when they're sent home,
Yeah.
what are the challenges you see, and what you typically recommend, how circadian rhythm of sleep comes into play?
Yeah. Um, that part, it's very understudied.
Mhm.
And so I think there's a lot of room that we can learn from and improve. And when we discharge the patient, we will write a discharge summary, write down what happened, what we think the disease is, what we have done. Patient's better, they're going home, so that the primary care physician can see what happened and treat. But we never talked about, sleep right, eat right. We don't do that. So the question is, are they back to that rhythm by the time they leave the hospital? And I don't think they are. The first thing is, when is a patient deemed okay to be discharged? It's when we think that there's no additional benefit for them to stay in the hospital. But that doesn't mean that they're completely recovered. The recovery happens actually at home, or outside the hospital. And hopefully most patients will have a home to go to, or they will have someone to take care of them. But most often they don't. And so they may be undergoing, may not have an optimal recovery environment. Patients who are survivor from ICU, they still have sleep disruption up to like maybe 2 weeks if you start measuring them by wearables. They have more they still have fragmentation, and sleep is less efficient. How does that affect? Is there a long-term effect on recovery or reinfection, readmission? We don't know. We definitely know that for ICU survivors, for sepsis, for example, there are a lot of people coming back to the hospital with another illness or the same illness, reinfection, for example. So if we could reduce that by optimizing recovery, that will be fantastic.
So you mentioned sepsis, and that's also one area where you're very interested in. Can you tell a little bit about what is sepsis? Annually, how many people in the US get diagnosed with sepsis? Because there are many who may not be.
Yes, yeah. So you can think of sepsis as the body's response to any kind of, I won't use the word trauma, but it is kind of trauma. But that could include infection, organ injury, and trauma. It's when you start having organ failures that can lead to more and more inflammatory cytokine level, so that your immune system or your body is overreacting to whatever you're experiencing. And sepsis is a syndrome. When we diagnose it clinically, they may be having a high fever, their peripheral immune cells count is going really high, their heart rate may be really fast, their blood pressure may be low. So we recognize those patients are having sepsis. Part of our job is to provide life support immediately, figure out what causes sepsis, and hopefully can treat it. For example, if it's an infection somewhere, we could take care of that infection and buy them time for the body to kind of settle down. Sometimes it takes a long time for them to recover, sometimes quicker. Worldwide, I think 19 million people globally have sepsis. I think in the US, 1.6 million.
1.6 million.
I think so.
That's similar to the number of people in the US who get diagnosed with cancer.
Yeah, sepsis.
1.5 or something like that. And in cancer, as we know, the survival has improved a lot. And also for different cancers, it's different. What is the survival rate for sepsis patients? 1 year survival, because as you mentioned, when they're released from hospital, it's not that they're fully cured. This is when you feel that not the cost benefit. The benefit to the patient is minimal if they stay in hospital, because they can get other infection or delirium, for example, they can get. So what is the survival for sepsis patients?
So now these are sepsis patients who survive ICU.
What percentage survive?
Maybe 30 to 40% survive from the ICU.
Really?
Yeah.
Wow. So the sepsis survival is way more worse than survival from cancer.
Yeah. You can put it that way. Yes, you can put it.
I mean, if you get diagnosed with cancer, you still have pretty good survival within 3 months. But if you are with sepsis, then your 3 month survival means surviving ICU means you have a double-digit chance of not making it out of ICU.
Yeah, because whatever caused that sepsis is so acute and so rampant. Sometimes the body can handle it, but a lot of times you can't, and it acts so fast.
Yeah.
The mortality is really high, and it's very challenging. Mortality has improved for sepsis because
survival has improved.
Survival has improved.
Yeah.
Because in the past 2 decades or so, we are doing a lot of landmark study, like recognizing sepsis early, treating antibiotics early, giving fluids early, and taking care of that infectious source early. If you've done things early enough, that helps with mortality. But there's still a lot of 20 to 40% of people still can't make it out from the ICU.
Yeah. And then those who make it out, what fraction of them come back to a hospital within a year?
So some studies say 30 to 40% goes back to the hospital.
Yeah.
And their 1 year mortality is about 40%.
40%?
40%, yeah.
So that's a lot of lives lost, right? So because if there are 1.5 million in the US alone, we are talking about few 100,000 patients actually not making it. So this is where I think this is the frontier this is the pinnacle of medical research, because when the life is on the edge and hours or minutes matter, can you save this patient?
Yeah.
And even when you save the patient, once they're released from hospital, can they come back to full play?
Yeah.
I always think of, disease has different stages. One is to prevent the disease from taking place. So that's where sleep, circadian rhythm, healthy nutrition, exercise all come into play. Second is, even if you have a disease, how do you accelerate cure or prognosis? And this is again where we talked about sleep, we talked about optimal medication, timing of medication. And then if you are severe enough, you go to critical care where, of course, in that stage, you cannot pay attention too much to sleep or but you can have care and you can layer circadian aspect on top of it.
Yeah.
And then finally return to play where you come out of hospital and being in bed immobilized for more than a week or so, you have lost muscle mass. You might have sleep disruption. Your brain may not be fully functional, and your organ systems may not be fully functional. And at this stage, there is not much research how to bring people back to full play, except maybe for cardiac rehab, because that area is pretty well studied, and almost I think 60% of people in the US who have a cardiac event, they go through cardiac rehab.
Yeah.
But for sepsis, there is no rehab process.
For sepsis, they first of all, there's no standard of no
Standard,
guideline.
yeah.
Yeah, no, not standardized, and a lot of those recommendations are not backed up by evidence.
Yes.
But we can learn from other field of medicine, just like you mentioned, cardiology, even from pulmonary medicine too. Like we have patients who have COPD exacerbation. They are hospitalized, and if once they're discharged, if they go to pulmonary rehab, which is a multimodal, kind of very holistic way of treating education, exercise training, learning breathing techniques, importance of medicine, the medications. If you do that, it will reduce their readmission rate or reduce the re-exacerbation rate. So things like that, I think it's effective. And I think part of rehab, it's kind of instilling circadian principle in a way.
Yeah.
The patient has to go to a place to get that rehab done. So they have to go, they have to be active. So in a way, when the patient is walking, exercising, interacting with people, I feel like that's a good sign.
Yeah.
And I don't know if we can pinpoint the scientific mechanism of what's going on, but it seems like holistically, when you see someone that can do that and they're pushing for that, I think that's a good sign.
Yeah, no, this is important for caregivers because the person may not be in a state to do complete self-care because in many cases, as I mentioned, they might have lost muscle mass, they may be feeling weak. But if the caregivers can enforce and say, well, you have to take 1,000 steps or 2,000 steps. Okay, this is the time when the kitchen closes, when the lights have to turn up and you have to be in bed. I mean, these are very simple stuff. Like, and as you mentioned, hospitalized patients don't get 8 hours of sleep. They get maximum what, 4, 5, 6 hours.
They're
Around.
5 hours. Sometimes they normal amount, but the key is it's fragmented.
Yeah.
And sometimes they're sleeping during the daytime.
Yeah.
And wake up at night. So it's that kind of disorganization. So
Yeah.
it's not just the total sleep time, but the quality of sleep.
Yeah. So fixing that sleep.
Yeah.
That kind of once you sleep at night, then it sets the rest of the day timetable in some kind of order.
Some kind of order, yeah.
Yeah, and then you can bring in, say, exposure to light, because those who have been stuck in this windowless room for 10, 15, 20 days, they also have some aspects of, brain health issue. At least they may be depressed or they may be feeling pretty low about themselves. So getting exposure to light, daylight for at least an hour or so, and just being outdoor and to socialize, those things are important.
That defines human in
That
many
defines
ways.
human.
Yeah.
So I guess you kind of said it implicitly. So that is, to have circadian rhythm is to be a healthy human.
Yeah. Yes.
Okay, thank you, Michael.
Yeah.
This was really pleasure, and you nicely guided us through the very basics of immune system and what we can do when we are preventing disease, when we are falling sick, what happens in the ICU and the post ICU.
Yeah. Well,
thanks a lot, and I'm super excited that Michael could spend some time with us, and maybe we can bring him back again because he's actively doing research on the effect of sleep or the effect of sleep disruption on our health. He's also, as you can hear, he spends most of his time in ICU care. And I always feel that the ICU physicians have way much more stress and responsibility because just one mistake or one delay in care or not communicating that care to the patients or to the patient's family can have huge effect, bad effect. And hopefully we can again share your
Yeah,
wisdom and insight into healthcare across the spectrum from being healthy to recovery from disease.
great.
Thank you so much.
Pleasure is mine. Thank you.
Thanks.
Mhm.
Thanks again for listening to this episode of Performance Around the Clock. I'm your host, Professor Satchin Panda. I hope you learned something new and found this episode exciting. If you did so, please leave us a comment. If you like the science that we discussed and would like to make a donation to research in my lab at the Salk Institute, you can do so by going to panda.salk.edu/giving. Thank you again for listening, and I'll see you next time.